Hey, Denise. Good morning. I think I'm on. Nick, are we okay to go? We're good. Well, welcome. Welcome to the second release of the community checkup this year. Really appreciate everyone joining in person as well as those who are online, working in the hybrid world that we are. And we also want to thank our sponsor, Genentech, for this series as we put out new information on the community checkup, especially looking at that equity lens using the area deprivation index. And today, what we're looking at is really what does the impact of where you live influence the cost of care as well as your health risk status. Before I get going too far, if you're online, mute your phones. We will have a Q&A session at the end of our discussion. There is a Q&A button, not the chat button, the Q&A button, if you want to put a question in there. All of this is being recorded, and we will put that out probably tomorrow. You will also receive slides. And we're going to have some polls as we go through this. So, mostly to keep you, interested and engaged, also see if you're still listening. So a little bit of both. But let's go ahead and get started. So I'm going to give a quick refresher, or maybe not so quick refresher, on what we presented in March and some of the findings that we had. And then we'll go into what we're seeing from a cost and a risk status. We're also then going to break in about 30 minutes and do a little panel discussion in terms of what those findings are showing, what was interesting, what was surprising, and start getting us prepared for sort of the what next. Later this morning, we have a group gathering to really start teasing out some of those action steps that we need to make, and how would we frame that, what other information do we need, and really appreciate those in the room who are joining us for that as well. So what's the community checkup? Again, real quick, it's about 4.5 million members, claims-based data. It's blinded for PHI. We have 31 data suppliers. And we've always sort of set our targets from a quality standpoint on that NCQA 90th percentile. What was new in March was we presented two sort of big things. One, what happens when you don't have a primary care provider? How does that influence your quality as well as some of the other access issues? And then what happens when we start looking at where you live within the state of Washington? And how does that impact quality? From a big picture, we presented this for a number of years. How does the quality of care in Washington compare nationally? And the size of those little bubbles actually are the size of the number of measures within those bubbles. You want more green than you want red. Red and yellow are those 25th and 25th to 50th percentiles, and we are running well below what the national averages would have us go with. On the commercial side, 81% of our measures are below the 50th percentile. Medicaid is doing a little bit better, a little bit more consistent, but still there's room for improvement in those areas. And the real question that I think the group wants to start tackling is, why would that be? Why do we see those discrepancies there? What is driving some of those pieces? Last September, we presented another view where we looked at the total cost of care and quality on an X and a Y axis. In the upper left corner is the highest quality and lowest cost area. And this is by county. You can look at it by medical group. You can look at it a lot of different ways. So because you can't read this, I'll tell you that Thurston, Walla Walla, and Spokane are the counties that are circled. So highest quality, lowest cost. And so this is on the commercial side. If you looked at it on the Medicaid side, you would get the same type of information. Later this year, we'll allow you the preference to say, I want a little bit more quality, a little less cost, vice versa. And so if your preference is really to have 75% quality weighting, you could do it that way as well. It's a pretty easy tool to use. We call it a preference slider. We'll come up with a really cute name for it. The other things we looked at was, primary care. And as a primary care doc, I always sort of myopically thought everyone had a primary care doc. We know that's not true. And on the commercial side, we see that about 20% of the population has claims in the system, so they're getting a refill prescription, they're seeing a specialist or whatever, but they don't attribute to a primary care doc. There's also about 14% of people have no claims at all. Same actually percent is true on the Medicaid side. About 20% of people have claims, don't attribute to a primary care doc. They have a higher percentage with no claims, but they also have a very different population, a little bit younger population. That may or may not make sense. Access may be the cause of that. We have to start teasing that out as well. And when you start looking at some of the quality metrics, we presented this the last time. Here's a bunch of screening measures. Here's the state average. You can see that we don't do as well from an NCQA HEDIS standpoint on most of those. The 90th percentile is sort of in the middle, but there are practices around the state that do fantastic, and they do well above the 90th percentile. But when you don't have a PCP, that's when you start getting in the red. Only about a third of the time are you going to get, annual cancer screenings. Only, a fraction of the time are you going to get appropriately screened for, diabetes. And you can keep going through this list and this is just a sampling of it. The other thing we presented was related to what we call the neighborhood atlas, or the area deprivation index. This was developed actually using the HRSA guidelines, which was more at the zip code level. They took it down to the census tract level. It uses about 17 different parameters of publicly available information, housing information, income information, employment, how many people live in the home, the quality of the homes, you have plumbing, things like that. And that's been correlated over the last couple of decades in terms of health outcomes. And we applied that to our data set. And the way we did it, we looked at it by deciles of where you live. Now, if you look at Washington compared to the rest of the country, that's what this view is right here. Blue is the more advantaged areas, privileged areas. Orange or red would be the more disadvantaged areas, and there is a spectrum along that. And you would say, well, it's kind of a little nice mix of blues and oranges, not too bad. Now you think about the rest of the country, Southeast United States, et cetera, that might be why. We decided we're not going to look at it from the state level, we're going to look at it compared to ourselves. So when you look at Washington compared to yourself, things become very orange really quickly. There are a lot of large areas where those populations are a little bit more disadvantaged using this tool. Reason we use this tool's free. Everyone can use it. It's very easily available. You can apply it to lots of different populations, and you don't need a lot of other information to get to it. So we feel that this is a really good tool to use, and now we want to see how does that compare to the quality aspects. And when we showed that, we looked at a number of things. So here's just a couple of screening areas. This is commercial population only, breast cancer screening up at the top. If you're in the more advantaged area, you're getting screened about 75% of the time, 74. If you're in the more disadvantaged area, you have insurance, it's only 61% of the time. These graphs look very similar no matter what measure you're looking at, although some of them are very flat, which is great. We'd like them all to be flat and all to be really high, but we don't see that all along. Medicaid looks a little different. They're a little bit more consistent than the commercial population, which is interesting. There's probably a number of reasons why a more disadvantaged commercial population may or may not be getting screened. Could be access, could it be I can't take time off of work, there's a cost involved. We know that almost 50% of the population cannot afford their deductible and their coinsurance, and that may be a deterrent. But there may be a number of other factors that we have to consider. And then we also looked at what happens when you don't have a primary care provider. This is a little bit hard to see, but the horizontal lines are your state averages for both commercial and Medicaid. And the other lines with the little red dots or red triangles mean it is statistically significantly different. And you can see that those both drop well below the state averages. And these are for those cancer screenings as well. So the impact of not having a PCP essentially means you are less likely to get appropriate care provided. And then there's also some evidence of potential bias. And this one is chlamydia screening women ages 16 to 24. The reason you screen is because that person is sexually active and you may be at risk for having chlamydia. You want to screen them. You can see that the state averages are in that 37 to 45 range. Best in state does a lot better. So why would you not be screening people? Do you think that only 35% of people in the more advantaged areas are sexually active? If you ask my 18-year-old, that probably wasn't true. And probably wasn't true for most of the people in her high school. So that really implies that there's a bias, and as you move to the more disadvantaged areas, those numbers go up as well. And we know that this screening goes up if you are brown or black or from a poor neighborhood. And that's been consistent around the country as well. So we're not seeing something different that we wouldn't see elsewhere. So those were the big things that we saw. Quality is an issue. Overall, lack of a PCP negatively impacts your quality issues. Having a PCP means you're not probably going to get screened, you're not going to close your care gaps, and where you live makes a big difference from a quality standpoint. But now we want to stop and ask a polling question, and I'm going to have Nick pull that up, I think. How's it going there, Nick? Showing online? Okay. I can't see that, so so I don't know what the polling. Can you read it out loud for us, and I'll repeat it. So where are you on the path looking at cost and equity? And where are most people falling on the not a lot to well on the way? So we're actively exploring or well on the way. So that's actually, that's good to know. So either you're trying to figure it out or you've got a path and you're working forward. So I'll keep moving us forward. Now let's look at what happens with risk and total cost when we apply ADI. We're going to look mostly right now at the commercial population. So when you look at that, just a couple of things. We're using a population risk tool out of Milliman, the Milliman Advanced Risk Adjuster. We've used that for a number of years as a way to risk adjust our population. So if we say MARA, that's what that means. We're looking at total cost of care. This is allowed charges, so we don't have any information on plan design, co-insurance, or things like that. So we can't make an opinion one way or the other on how plan design may be affecting people's behavior. But we want to see what happens when you start adding ADI to this. So here's all those deciles. So we're looking at commercial. These are the deciles across Washington State. The blue bars are those people who've had claims, and you can see that they sort of peak in around 3, 4, fourth decile area, and they start tapering down. You'll also see that there's a lot of numbers and belly buttons in each of these things. So well over 35, 40,000 even in the lowest area. So this is credible data as we look at it. And then as we look at what happens to the risk score, but also what happens to, do people actually access care? Do they get a claim within the system? When we look at that, on the far left, that is your most advantaged area. And you can see that your risk score is also the lowest. and most people are having a claim. So 5.8% of the time they have no claims at all. Now, as you move to the right, you start seeing that both curves go straight up. And your risk scores go up, as well as your avoidance of care goes up. Now, people might say, well, it's people in those areas are just younger and they don't need any care, and that might be true. We don't know that for sure, but it can go up to 13% of the time that you have no claims within the system in that last year. So something's happening different in those communities. What happens to cost? So if you look on the left, we're looking at it from a purchaser point of view because they are paying the bills. So we are including the outliers. We are not risk adjusting. And you can see that the cost goes up as you get into the more deprived areas. Now, if we just say, let's just look at people who had a claim, that curve looks a little steeper because you have increasing numbers of people without a claim. But it's essentially the same story. Costs go up over time. And then the question really starts getting at, well, where are those costs? And we'll start looking at it. I did want to show a couple of screenshots to what's on our community checkup today and how you can start searching for that. So this is a, just a quick view. You can choose by, commercial payer. You can choose by both, Medicaid and commercial. You choose, what deciles you want to look at. So if you only want to look at one decile, I guess you could. We typically look at all 10. You can look at the service settings. So do you want to just look at overall, or do you want to look at, is it inpatient, outpatient, ancillary, et cetera? So there's a lot of ways you can cut this as well. You can look at counties, et cetera. And you'll be able to, get these curves. The reason I'm not always showing that, these aren't as pretty as the other slides that Jim put up. I have a question in the audience. Go ahead, Michelle.
Can you look at it also by
Yes, you can. The question was, can you look at attributed versus non-attributed? And so this year, what we put in was you can look by medical group. And so if the medical group has, and the way we publicly report it, we report it if you have all 10 deciles within your medical group, you can get to that. If you're a medical group that's in a community that's a member of the Alliance and doesn't have someone, we can pull that data for you. But you can also look at not attributed to a PCP. You can also look at, there's groups that are too small that we don't assign to a medical group per se, and you can see that number as well. So you'll be able to see a variety of different slices to that, but that's a great one. And when you start looking at costs, there's a couple of things that start popping out. Most of the time when we think of costs, we either look at total costs overall for a population or maybe the average cost. This is looking at it two ways. One is the bottom line is the median. So what's the median number so the statisticians in the room are going to go, oh yeah, median number. That's great. That looks kind of flat. The average is, what the total average is. And you'll see it starts widening up, right? The bottom one looks a little bit flat. It actually went down about 7%, so that the median number drops down. But when you look at the average number, it starts going up. And that tells us that there's more volatility. There's probably more intensity of service. There may be some other factors that get in there, high-cost claimants, things that we don't have access to currently with our database. What happens when you don't have a PCP? Are you delaying care and getting care in more expensive type facilities? And we'll take a look at how that might look. So this is pulling out also from our community checkup, and it's looking at PMPM, really hard to read. The colors might help. And this is looking at how you can choose by all settings, so the cost within the total group, but also by, is it ancillary, inpatient, outpatient, professional services, or pharmacy, and how those align. You can also then screen and look at it by population risk. So using those MARA scores, does that actually align with the costs that you're seeing overall? And to a certain extent, yeah, maybe. So here's facility. And so this is looking at the facility risk on the right. And you can see that as you move up in a decile, And this is specific to inpatient facility by the member. So that member who's in decile number 1, who was admitted to the hospital, has a risk score of, and now I can't read it, 0.84. So pretty low risk. But that's just the people that are inpatient. And then you can look over to the other side and see, is their cost low? And you can say, yeah, it was lower. So that sort of makes sense, right? You can also look at some other ones and you can say, well, here's professional. These are office visits. So in the top 3 deciles, your risk score is pretty average, right around 1. Your costs are a lot higher. So the people in the more advantaged areas are getting more office visits, more lower cost care, more coordinated care is what we can assume. And is that impacting the fact that they have a lower risk score and a lower hospitalization rate and lower costs? Because the costs are actually lower. So maybe that's a better thing, and maybe that's a view into access. What if we look at the Medicaid population? So the Medicaid population, same type of thing. Here's the deciles going across. More people in the... Okay, I think we're back. We don't know. So there's a couple questions. I apologize for the technical stuff. The good news is when we record it, and then we can like edit those things out, it'll look almost seamless. So we talked about Medicaid. There were some questions about do we have any data on the plan designs and the cost differentials, and certainly we have on the commercial side. We know all those unit costs. We just don't report them. On the Medicaid side, there's a little bit more consistency on that. And what we were showing here were on the left, you see all the different deciles of where the Medicaid population comes in. On the right, what happens to their risk score? So blue is a risk score. It dips a little bit in those deciles 3, 4, and 5. Then it kind of slowly goes up a little bit. The interesting part is the people accessing care actually gets better in the more deprived areas. So that may mean either they have more chronic conditions or accessing care. Maybe they have services that are easy to get to. There may be a variety of factors on why that population uses services more than maybe those in the 98004 area. And I'm going to just keep moving along pretty fast there. So here's your cost on Medicaid. So this is looking at general Medicaid. Overall costs are lower even when you exclude the non-utilizers. Those costs are lower. And I'm going to just highlight a couple of little dots because I know Dr. Chen was wondering, why are those dots up so high? Those are where we don't have ADI information or don't report it. And on the Medicaid side, that can be a lot of the people that have disabilities. So we didn't want to confound the numbers that way to make it skew one way or the other. So the 0 or no ADI is a somewhat different, higher risk, higher cost population, which would certainly make sense. But what else are we saying, from a service line standpoint? And these are from the community checkup. Most things are going to be green because the costs are below the state average, even when you risk adjust. Oops. This is looking at prescription drug costs. You'll see it's sort of interesting. In the upper deciles, the costs are higher for Medicaid on prescription drugs, and the risk score within that category goes down. So that would make you think that as you get to the more deprived areas, the risk, if you need a medication, your overall risk score, your MARA score, goes down. I'm not sure that's true or not, but that's what the data would suggest. If you look to the left of that, you can see outpatient facility. There, your risk scores stay about the same, but your costs go up. So that implies that maybe what we're starting to see is the use of outpatient facility services, ER, outpatient surgery, et cetera, may go up in those higher decile regions. Then when we look at a little bit of both, so this is trying to look at both of those areas, commercial and Medicaid, what happens from a risk score standpoint. On the commercial side, it looks pretty clear. As you move from left to right, those risk scores continue to go up. When you look at inpatient facility, those go up, 20+%. And when you look at the Medicaid side, you really have to try to ignore the none category, those people with more disabilities, et cetera. But even when you do that, that one looks a little flatter except for that pharmacy component. Now, what happens when you don't have a PCP? Because I know Michelle, has that one, top of mind, right? So when you don't have a PCP and we start arraying things by commercial and Medicaid, those decile ranges look very similar to what we saw before. Commercial leans a little bit more to the left, Medicaid leans a little bit more to the right. But what you also see is increasing risk scores, especially on the commercial side, and not so much on the Medicaid side. It stays a little bit flatter. When you start looking at costs, so this is cost for those populations, and you would say, well, shoot, cost is a lot lower. Maybe we should never give anyone a PCP. It would be a better deal. Although I probably wouldn't agree, but you think that way. But when you start thinking about their risk score and you adjusted cost for risk score, now they look very similar to the rest of the population, although a little bit higher in commercial on the lower deciles. So that sort of lets me know that, gee, these people are lower risk. You would have expected them to stay lower cost, but when you adjust them, they're right in the middle with everybody else. Then when you start looking at, well, why are their costs higher? And up at the top, this is looking at on a per patient per month, all setting commercial, and what's driving the commercial costs is inpatient. These people, and we've risk adjusted, so what's driving their costs up is the fact that they have a higher cost on the inpatient side than you would have expected even at the state level. On the Medicaid side, it's really being the cost is being driven a lot by those non ADI populations, and it's very much on the inpatient side. But I think it's telling that maybe what we're seeing without a PCP is people in the hospital a little bit more, or at least higher costs within the hospital. And then when we also look at their risk scores, we can look across the commercial population. They tend to go up as you get to higher risk scores. On the Medicaid population, it's that prescription drug one which continues to bother me in that it goes down as you get into the higher deciles. It almost feels like it's improving rather than getting worse. And then one last one in here that was somewhat interesting. When we look at the non-PCP and we look at their risk score, we also were able to start teasing out how about the populations within those groups that didn't have any care at all. And we saw this in one of the first slides. On the far left, decile 1, only about 5.8% of people did not have a visit or a claim, 13.3 on the decile 10. When you look at those without a PCP, and this is looking back a couple of years, those numbers go way up. So those numbers, almost a third of the time, if you don't have a PCP and you're in a decile 10, you did not access any care in the last couple of years. So that one seems more worrisome than some of the other ones. So what we've seen is the risk keeps going up. They may not be getting claims at all. We know from our previous release that quality gets worse without having a PCP. And is it that avoidance that's making the quality worse, or is there something else? And is that really driving those gaps in care? So this is what we've sort of seen on the commercial side. Risks are going up. I'll let you read all these things. Costs are going up. We see a lot in the outpatient facility standpoint in terms of some of those costs by ADI. Professional costs seem to be inversely related and maybe a factor in lowering the total cost of care. And when you don't have a PCP, that's certainly impacting things, especially on the inpatient side. Medicaid looks a little flatter. They seem to be much more consistent in terms of both risk scores, access, cost, and maybe there's a difference in terms of the outpatient facility, but that one is much more consistent than what we saw on the commercial side. And there may be other factors associated with that. The population's a little bit different as well. And so what we want to do is figure out how we start putting all of this together. And we know that where you live matters, and we saw that on the first time. Quality makes a big difference. You know, much more likely to not receive appropriate preventive screening or management of your chronic disease. And then what we started seeing today, risk status starts going up. You know, those are, you know, acute, complex factors. And the cost seems to go up, and it gets exacerbated when you don't have a PCP. So what I want to do is, we're running a little bit late, and we'll go fast, but I'm going to break and bring Mark and Jim Andrianos together, and I'll sit with them, and we'll have. Let's see if that works. We'll have a little discussion. We're still on the internet, so far so good. And so Mark Pregler is our Director of Data Management Analytics. Jim Andrianos has been part of the Alliance work for years, since the beginning? Almost the beginning. And so these guys can get into a lot of the details and the data a little bit more than I can. But what I want to do is just, you know, ask you guys a question. And Mark, do I hear you on the phone?
I hope so. Can you hear me?
There you are. Perfect. We can hear you loud and clear. So for either one who wants to go first, did you see what you expected to see in there?
Thanks, Drew. So in terms of surprises and seeing things I expected to see, the details I think Drew has covered pretty well. What I wanted to do with this in the limited time is to talk a little bit about patterns of patterns almost, because in working with, you know, especially this year, the quality stratified by ADI and now the cost, what I'm seeing is, we'll start with commercial. The pattern that we're seeing on the quality side, as you saw with the cancer screenings, is declining performance in the more deprived areas. And then that pattern continues with cost, which we might not be surprised by, and by illness burden or the health risk, which we also might not be surprised by. But then we have that the continuing pattern of declining performance when we think about people who have insurance and they're not using it. So the theme on the commercial side is decline in performance, not always, but often, decline in performance as deprivation rises. And then on the Medicaid side, really a very different picture of, as Drew said, consistency. And we're seeing it in quality results, cost, health risk, and people using insurance when they have coverage. And just to keep the topic at a high level, I wonder if there's any way possible that the commercial side of our healthcare system can learn something about better consistency from the Medicaid side. Why not? You know, let's put a couple of people in a room and see if there's possibilities there. Because the Medicaid consistency is, it's almost as if the Medicaid service is immune to ADI effects, which is a kind of a wonderful thing if you think about it. And then on the Medicaid side, is there something they can learn from the commercial side? Because by and large, while Medicare is flatter, they tend to have performance levels that are not quite as good as commercial. So in terms of just improving nominal performance, there might be something that the commercial side of the industry can help Medicaid with. And you know, that's sort of the one thing I wanted to mention. And the last thing I want to say is, although that might sound a little dreamy, I wanted to make sure that everyone is aware that, in a sense, the Alliance is somewhat behind the curve vis-a-vis ADI, because the biggest purchaser in the country, CMS is using ADI to modulate equity-based payments to their accountable care organizations, the REACH ACO program. So I could have jumped right in and said, hey, let's think about pay for equity, but quite frankly, that's already happening, and they're using the exact same tool that the Alliance is using.
Mark, what did you see in the data that either things you expected or things that may have surprised you?
I think a lot of it parallels what Jim said. I think going in, we expected to see some variation across deciles, a little bit of a roller coaster, not necessarily uniformly trending upward or downward. We knew from our early reports, some of you in the audience may remember our different regions, different care reports we did, it's probably been 5 to 8 years ago. And we knew there was variation based on where you live. But what this does with the ADI, it gets us a little bit more granular using that census block. It allows us to subset those areas that we looked at in the different regions, different care series of reporting. And the expectation going in, ADI was new to us. We had our data. We're going to look at this. We're going to see some variation. Not a big deal. But what was most surprising is how much variation and how the pattern from least deprived to most deprived neighborhoods really stood out to us. It was very surprising. And I think, Drew, as you talked about the cancer screenings in particular, the quality impact there is quite significant, from high to low. And the risk scores, the population risk in these deciles was quite striking and unexpected. That there would be so many differences. And we understand based on the 17 attributes of ADI, income and the neighborhoods may vary. But you think in terms of the healthcare system, at least an expectation was everybody's somewhat getting the same care, but they're not. And I think the reports and the data that we've put out today with total cost of care by ADI reflect that. And, as a community, as a stakeholder body, we're going to have to start looking at how we're going to address that in the future.
Thanks. The other question and some of the questions that came up while we were not online, what other information, can we get? What other information would you want to be able to look at and or report on that might help tease out, some of these kind of big swaths, which are sort of county level or insurance level or even at a medical group level? But what other information would you need, do you think, to be able to tell this story a little bit better? Mark, I'll go to you first.
Yeah, so, from a data perspective, we have a lot of data in our database. As you said early in your presentation, 4.5 million covered lives. We have data that goes back to 2004, so it's quite a substantial database and has a lot of the attributes that we can explore for understanding drivers, what may be driving some of these differences across the deciles. Cost and utilization is a big one, looking at utilization patterns, looking at unit cost patterns. We have the data to do that, but based on our current data supplier agreements, there's some limitations in what we can expose or report publicly. So we have to be able to address that with our suppliers to take that deeper dive. The other thing I think that's important to call out is while ADI looks at socioeconomic factors, it's based on 17 attributes from the census, the American Community Survey. It doesn't touch on race, ethnicity, or language. And I think those are important attributes that we need to collect in the data. I think from the standpoint of data collection, it sounds easy, but the reality is we don't have a good source of where we can get those attributes. But I think digging into the racial, ethnic disparities that may be there is going to be a very important piece in the future to understand what actions to take and where to change.
Yeah, I can add on to a wish list of data that would help the Alliance with its work. One would be, so affordability is a big question. with some of the charts that we've seen, why is it that people aren't using their healthcare? Why is it that, et cetera, et cetera? We need to see in the data submissions, we need to be able to tell whether the servicing provider was in or out of network. So one idea is to have data suppliers send in an indicator that simply says, yeah, this particular claim line was adjudicated and it was an in-network transaction or an out-of-network transaction. And from there, the Alliance can begin to, estimate and basically create, per person, estimates of out-of-pocket expense. I'd be fascinated to see what that looks like stratified by ADI. And if it were flat, we would be able to rule something out and be surprised and happy and move on to the next potential explanation. Another one is, we got a question recently on the quality stratified results, which was, hey, how do those quality scores look when you divvy up the data according to the type of value-based contract that is in play? Because as the questioner asked, it would be terrible if when you had a value-based contract operating, that quality was actually suffering. So another idea is to work with data suppliers to come up with a very simple taxonomy of, say, 3 or 4 or 5 or 6 categories of value-based contracting, without disclosing terms, and use that information to stratify quality performance and cost performance, for that matter, on the basis of the nature of the value-based contract. And of course, all of that would be the baseline to all of that would be the run-of-the-mill vanilla traditional fee-for-service, status quo type of contract. So that's a couple I would add on with Mark's idea of getting agreement for the Alliance to use the data that it already has regarding price level and utilization.
Thanks. So, Mark, what I heard was we've got a lot of data. We just need to be able to get to it. So things like we see costs at a certain level, we want to understand, is that a utilization issue, a unit cost issue, which may be a contract issue, maybe an intensity of service. Is it a ICU admission versus a med-surg admission? Those are very different cost categories. Is it a different, because you have different contracts, is it the facility that people are going to that may be lowering the cost or increasing the cost? And then I think the important piece that you mentioned was sort of twofold. One, what's the plan design? How does that impact people's behavior or access? And then on the provider contract side, are they being incented on a quality and an access standpoint to be able to improve care? And does that actually make a significant difference that's measurable? Yeah. And so I guess the next question I had for you, and I know we're getting close on time, was if you could talk to these different communities where you may want to address an equity issue and or a quality issue, what would you want them to do? And I'll start with Mark, because you're up there smiling.
There we go. Yeah, this may be pretty obvious to others, but we need to do more with primary care. I mean, we have a pretty substantial population that we're finding with this new grouping. They're just not getting services, and the risk scores reflect that. I'm not talking about from a payment reform perspective, value-based benefit design or anything. We just need to be encouraging people to go have a primary care relationship and get simple screening, simple care. Have that relationship, go see the doctor. And, I think in the end, we want to see those risk scores come down. We want to see the costs improve. And And I think as a collective body, as an industry stakeholder community, we should be able to achieve that relatively easy.
I would say this is going to be a little bit vague, but I think that there is an opportunity waiting for some group, entity, organization, doesn't have to be in healthcare. There's an opportunity to go about targeting some of these underperforming areas. I mean, we have cost, we have quality, now we have an equity dimension. Surely we really don't need to wait much longer. There's plenty to act on now. There's an opportunity to target some of these underperforming areas in a way that gives, supports that help the areas attain levels of achievement that we would all be comfortable with, regardless of where we lived and in what circumstances. That could be a community-based effort. It can be an enterprising health plan or delivery system could take charge of that. It could be governmental type of entity. But the data, it now exists, and it's sort of there for acting upon. And the Alliance is in a great spot to facilitate or broker that type of work, because those are some of the other functions of the Alliance. I think, waiting for the Alliance to do that work might not be the right approach, because so much of this is out in the field. But the data exists, and it's an opportunity. It's a huge opportunity.
And probably for both of you, do we have the tools right now to measure that, any of those activities might be successful? With the data that we have presented today, or maybe even some drill down data, get us the ability to say, yeah, we're making inroads within a specific community or the state at large?
Well, we could certainly rerun this report as a monitoring service and see whether things are, improving or, remaining as they are or getting worse. So that's always a possibility. Mark?
Yeah, I would agree with that wholeheartedly. I think, the data will tell us if there's improvement. It will tell us if there's not. And I would just continue to encourage that we move forward trying to take action and then monitor it over time and see what's happening. If we're not improving, then we need to figure out what the cause. There's got to be another root cause that we're just not seeing.
Well, thank you both very much. We have a couple of questions in Q&A. We got about 4 minutes left, so let's see what they might be.
Wondering if the consistency in Medicaid versus commercial has to do with access to care, not access to insurance. So the ADI areas that are red may better access to care related to community health center locations, and that commercial insurance has higher out-of-pocket costs, with which the literature is quite consistent is a barrier to care.
Well, we have someone in the audience who's about ready to answer, but I think I think that's that's sort of the assumption, right? Because on a Medicaid side, there's no out-of-pocket expenses that you're going through, and certainly on the commercial side, if you're in a more deprived area and you've got a co-insurance or maybe a high deductible plan at $1,500 for an individual, $3,500, $5,000 for a family, you might have access, but do you really have access? And you may be just delaying care, and we see that around the country fairly consistently. So that may be a factor. Community health centers, I used to work at one. They take commercial insurance, but people don't necessarily know that. And you can get pretty darn good care at an FQHC as well. But I got an expert in the room over here, and I'm going to just walk over and hand him a mic because, why not? So.
I definitely would not call myself an expert, but and I'm Chris Chen. I'm a medical director for Medicaid at the Healthcare Authority. I think the key thing about Medicaid is just remembering our eligibility. And so we've got 2 million folks on Medicaid in the state of Washington, and a lot of eligibility criteria. But one of the key ones for kids is being in a household with an income less than 300% of the federal poverty limit, and for adults with the Affordable Care Act, less than 138% of the federal poverty limit. So if we focus on adults, federal poverty limit around, I don't know, it's like $15,000 or something. So like a household of one, that's an income of about $18,000, and that's adjusted on a geographic basis. But basically, you know, you've got 1 million adults in the state of Washington who make less than, you know, a certain amount of money. Now, if the difference between the commercial, using ADI and the commercial and the Medicare side, then on the Medicaid side is Medicaid, you already have that predetermined eligibility criteria. And so it doesn't matter if you're a Medicaid client living in Bellevue, using that as an example again, or a Medicaid client living in Yakima, you're still a Medicaid client. And that means that you still have an income less than a certain amount of money, which I think is reflected in kind of the distribution as the percentage of the Medicaid population, and also kind of may have some implications on the quality of care received too. You can imagine if you're a provider in a rural area that relies more heavily on a government payer mix, like Medicare, Medicaid, you might have developed some more clinical workflows or have more familiarity with the population in terms of addressing their social needs, et cetera. So I think that's just one thing to consider for ADI analysis for Medicaid.
Thanks, and I think we're almost out of time. Is it a quickie? 2 minutes and one more question, okay.
Regarding the Medicaid and drug costs decreasing in the highest ADI areas, is that due to the lack of access to specialists by this population with higher ADI, with less resources or ability to travel to or access specialty care, thus less high-cost specialty drugs? Or has this issue been controlled for in the data?
So the question about, you know, does the lowering cost of pharmacy spend on Medicaid reflect that people maybe aren't getting appropriate medications or not accessing specialists, or maybe it's being addressed and adjusted for? It's not being adjusted for in our data, but that is sort of the work that I think we need to try to figure out and tease out to say, is there an issue here, yes or no? So what we're doing as a group today, and what we need to do in the future, in about a half an hour, we're going to have about 25, 30 people together to start trying to figure out how do we want to use this data, and how do we want to answer some of those types of questions, and what other things do we need to know to be able to answer specifically, why is there that difference? Why? Because you almost figured that the cost would go up, you know, as you went into deciles, not go down. And is it real or not? If it's real and it's fine, that's great, and we move on to the next one. If it's not, then what's going on? Is it a specialty access? Is it a specialty drug distribution problem? Probably not, because you got, you know, people tend to get mail, so that should be okay. But that's what we're going to do for the next 3.5 hours that we're here together. I want to thank people for being on the phone. We've got a number of things coming up in the future. We've got a behavioral health forum next month. We've got a couple of DOH presentations on tobacco and hypertension coming up. We have another release of the community checkup when we use our waste calculator in probably Q3. We'll have that preference slider that I mentioned earlier, where you can choose between quality and cost, and how much you care about one or the other, and where does that change maybe where your county is from a distribution process, or even a medical group from that process. And with that, I just want to thank everyone for joining. Thanks for those in purpose. And oh, there's one more poll. I'm sorry. Of course, I forget the polls, but because I don't have my slides up, so now I don't know. So we're launching a poll, I hope. See the poll? So it's the question I keep asking. What other data would you like us to get, and please write those down. I think it will come up as a word cloud. Is that what happens with that? And we'll be able to show that and start being able to collate that. It keeps coming. Okay. Well, great. And then are we done? Race, ethnic, income level, patient, satisfaction. Yep, we've looked at trying to get access to that, what types of jobs people might be. Are they employed versus not employed? Good ones. Do they have a provider? Do they have a, I don't know what a definition of it here. So utilization, type of data, maybe location, type of facility. Ethnicity keeps bumping up. That's good. Language, I'm sure, is in there someplace. Yeah, right. So if we had access to that type of information, yeah. Okay. Well, with that, I think we'll leave the poll open for a little bit, but want to thank everyone for joining, and more to come after this. We will send the slides. We will send an edited version of the presentation without the big gap in there. If there's other questions that came through the chat or through the Q&A, we'll try to answer those. We'll put this out probably within the next 48 hours or so that everyone has access to it. And then the work group today will have some work that we'll do and some takeaways and some action steps as we move forward in trying to tease out how do we address these discrepancies we've been seeing within the state. So thank you all very much, and have a great rest of your day.